Hi, everybody. Dr. Jessie here. I'm on the women's side of things at CHIRO for Moms. I'm here with Dr. Sarah Manneh. Manneh. I was practicing it for because I've been calling her Manneh. It's a beautiful name. Anyway, we're going to talk VBAC today, which is pretty neat because there aren't a lot of clinicians who specialize in this. There aren't a lot of clinics who will even do it. And Dr. Sarah here, Manneh, is an incredible expert. I've had the experience, fortunately, of dealing with her on the chiropractic end of seeing what her patients are going through in the process. And it's been eye-opening and pretty joyful, to say the least. So I want to start with you just explaining a little bit about yourself, and then we're going to dive right into the top kind of 3 questions that you get from families when they're making a choice to go VBAC.
Yes, as you know, I'm Sarah Manneh. The name is amazing, right? I inherited it from marrying my husband. I've been in practice for now going on to the 19th year. First 3 years was with a different group, but now I've been exclusive with a group called Oakdale OBGYN. The group is based out of Maple Grove Hospital. We do all of our babies there, but the name itself is misleading. It's not Oakdale, Minnesota, but off of an avenue we started off in. But so we work in Plymouth and Maple Grove and also in Blaine. Those are our 3 clinics.
It's awesome. In a long time. And
a long time, yes.
Maybe we start with what a VBAC is. I mean, and then maybe those top 3 questions, but I just realized I didn't even explain what it stands for.
Yeah, so there's two basic terms. Basically, VBAC stands for vaginal birth after C-section. And what's now more kind of, I guess, PC or globally known is something called TOLAC, TOLAC, which is trial of labor after cesarean section. So the 2 terms are interchangeable, but it's basically the first attempt or sometimes many attempts after a prior cesarean section. But the critical is that first attempt after one C-section.
That's actually really nice for people to know, because when you're in conversation, it's good to know that they are interchangeable and you're not talking about 2 different things. Okay, yeah. Top 3 questions, what are they?
Top 3 questions. Gosh, first,
I dive into my own if you want. If you
go ahead. You give me that because I can go on and they may vary. I think whatever people want to hear.
Yeah, I absolutely. And I know we kind of went over this prior, so you kind of know what's coming. I want to know, because the number 1 question is going to be the danger surrounding a VBAC.
Yeah.
So I'd like to just start it there and get it over with. What are the dangers? So
most women today will have a C-section that's called a low transverse uterine incision C-section. So if you think of the uterus kind of, this shape, it's that incision that goes left to right, not the skin incision, but the incision that's on the uterus itself. So that's low transverse. If the uterus was cut into, again, like this, but cut into the center of it, that's called a classical cesarean section. So in women who have a low transverse cesarean section, their rate of uterine rupture, that entire uterus opening up and tearing open, is less than 1% if they are very good candidates. And when I say good candidates, we have to kind of weed out who's going to be a great candidate. Now, if it's a classical up and down C-section, the rate of that uterus tearing open when a woman's contracting and trying to have a vaginal birth is 20-fold. That's like 20%. So in those women with classical cesareans, we don't ever let those women VBAC. And also there's variations in the C-section scar. So if there's any vertical extension of that incision that was like this on the uterus, but upward even by just a little bit, she won't be a great candidate and she'd be advised not to do a vaginal birth after cesarean. So the true person who's a great candidate is if that low transverse incision is, documented on that surgical report. And also if she's had at least 12 months of healing between her low transverse incision and her attempt to birth. So anytime shorter than that, she's going to not be a great candidate and she may have higher risk than that 1% of rupture.
That's really good for women to know.
Mm-hmm. Yep.
I guess then I want to go right into the benefits.
Yeah, the benefits are huge. I mean, right, recovery time is less when we think about a cesarean section and the time it takes to heal. Most women are in the hospital 3 days max. Sometimes they'll stay in a 4th day max. And when I say that, day of surgery doesn't count. It's day after surgery, 2nd day, 3rd day is how long they stay in the hospital. So their hospital day, time is different. In a vaginal birth, those women are staying in the hospital for about 2 days, right? Some women, they'll go home sooner than 2 days. They'll go home potentially in a 24-hour transition. But from the overall 6-week postpartum healing period, which is when I think, Jesse, you and your staff see a lot of our women in that transition of trying to recover postpartum, you'll see women where their incisions are still tender. If it's a C-section incision, if there may not be moving well enough, they may have a lot of back and shoulder pain because they've been in the operating room on an operating table for an hour or less during her C-section. So in those women, the pain is different. The recovery time with incision and moving is different. Their lifting restrictions can be different because we want them to be under 20 pounds of lifting. So that can be separate. In a vaginal birth, normal delivery, I mean, she's probably, oftentimes if the tear isn't big and she doesn't have pelvic floor trauma, she can be back in shape in about 2 to 4 weeks. Probably, less incisional abdominal pain. She may have some shoulder back pain because she's breastfeeding, but I would say the degree of pain and recovery is probably 2 or 3-fold more so than in someone who's had a vaginal birth. That was not a traumatic vaginal birth.
I guess that leads me into the next question, the traumatic versus the non-traumatic.
In terms of like C-section, traumatic, yeah, that's important, right? So you have women who've had an attempt for a vaginal birth, their very first maybe vaginal birth. And then all of a sudden there are fetal reasons or maternal reasons that go to urgent or emergent C-section. So in those women, if they've labored, experienced just also the physical hardship, and this is why we call it labor, right? That physical hardship of labor. And then they go to C-section, those women actually recover harder and maybe more higher risk to blood loss infection than a woman who has planned her C-section. Right. So say you've had a C-section or you have a breech, you've had a C-section before, or you've had a baby who's breech and you'll need a C-section. Those women, when it's planned and scheduled and they haven't labored before, their recovery is probably going to be better than someone who has had, dual trauma, right? Trauma of vaginal birth that then led to C-section.
That makes a lot of sense.
Yeah.
What is the success rate with a VBAC?
So I'll just paint out really quick what I would say is an ideal candidate. The ideal candidate is someone who meets a certain body mass index, a certain weight criteria. If she's had a non-recurring event in her vaginal birth trial, that makes her a good candidate to try a vaginal birth, meaning say she had the reason for her C-section was breech. Well, we don't expect that breech will repeat on a second time. Right. So that's a non-recurring reason to say she's a good candidate. But say your baby was 10 pounds before, genetically, we think this baby is going to be in her vaginal birth trial, a 10-pound baby. Well, that's a recurring potential risk that may lower her risk factors. So if she is actually an ideal candidate, normal weight, healing time from C-section to this trial over 12 months, maybe a breech C-section before, but this is a non-recurring event, maybe heart tones, baby was struggling first, delivery to C-section, but now we think baby won't struggle on this attempt. Her success rate's over 70%. Yeah, it's over 70%. So we should be VBACing women. And the reason why we don't VBAC women, and this is the national norm with American College of OBGYN, my college that represents OBGYN physicians, we should be VBACing women, all of them, if they're perfect candidates. But the reason why we don't is because we are struggling with malpractice and higher rates of risk to groups who take that on. We're struggling with lack of availability of 24/7 anesthesia if there is an urgent need for a C-section or lack of 24/7 present OBGYN doctors that are in the hospital. So logistically, it's a combo of things that prevent women from VBACing just from the institution, right? The institution and the practice. But from the standpoint of having women find the right providers is the other barrier, because I think they are led to believe everyone needs a C-section and they can't find the right providers who are willing to do it.
Yeah. We're going to run out of time.
I know.
I have so many more questions, but I guess
I know.
I'm going to say with this too, for any of you women watching this, you're watching this for a reason, because you have questions, and I'm going to encourage you, this will all be in the notes as well, but I'm going to encourage you to really reach out, to talk to somebody like Dr. Sarah Manneh, really find your places and ask the questions, and don't be afraid to. I have one last question.
Yeah.
When you decide you have a good candidate for a VBAC, what are the things that you're recommending in prep for VBAC? Obviously, I'm on the body mechanics side of things, but I'd like to know kind of all encompassing in brief what you would recommend.
Oh my gosh, the body mechanics are key, right? So again, we're talking about women who are normal weight. They're going to be more successful because there isn't a structural barrier that is preventing baby from coming down when we're talking about obesity and extra weight. So normal weight, really great abs, right? It's the ability to push your baby out, having a strong pelvic floor, having, very mobile hips. Those are the things that all women really need to work on when they're coming into a vaginal birth trial. And remember the resilience it takes to just get through labor. I mean, you need cardiac endurance. You need to be healthy overall, because it's work. It's work. So the more healthy that you are, and truly the more fit and the more able that to have been prepared physically prior, the better the outcomes are going to be.
That's amazing. And it's good to hear.
Yeah.
You're incredible. I think what you're doing is incredible. And I'm really grateful for this time, because I think it's going to make a difference for a lot of women, just being educated on it, knowing the questions to even ask, where to start. So
right. And I'm just going to put out a plug. I actually did a very long video on vaginal birth after C-section. I won't say very long, but it's more than our time, but it's with my group. And if you Google Oakdale OBGYN.com, there'll be a link to the VBAC video that I put out. It's also on YouTube. And it does really go into just kind of the more specifics of what we're looking at. It's an old video, which is, I'm like, God, do I really look like that? But yeah, but it's applicable. It's still all the numbers and data exist the same.
We'll link it as well.
Yeah.
And everywhere we're sharing this kind of information, we'll be sure to link that, because it's nice for people to have a longer resource. Because again, these have to be kept relatively brief. So
for sure.
Thank you. You're
oh
amazing.
my gosh, Jessie, thank you. And thank you for being such a great resource, you and your team, for my patients. And I am passionate about this job and saying the right things and doing the right things for women, which is what you all do. So
wow. So grateful. We're in it. It for the women.
Yes.
Families too, but
yes.
Love those women.
Yes.
Okay, I'm gonna end this now. Thank you. Bye.
Okay. Bye.